but is slightly less efficacious. There was some discussion about pancreatitis because these drugs like GLP-1 is anti-apoptotic, which means there might be some ductal proliferation, but until now there is no signal for pancreatitis or even pancreatic cancer, but still we have to observe those data. What you can see is there's a lot of incretin-based therapies currently under development. Some of them are on the market already. So let's turn to insulin. At some point when the beta cell is exhausted and patients need to be put on insulin, this is the insulin molecule, and we have a lot of different analogs now. Short-acting analogs, long-acting analogs, like the short-acting Lispro, the Aspart, the Glulisane, which have a very short, quite short duration and a rapid onset. And of course we have those long-acting 24-hour acting insulins like insulin glargine or insulin detimir. So how do we apply insulin? And this is a stepwise approach recently published, which means that if you have somebody on medical treatment, oral antidiabetic treatment, you start insulin treatment, you might either choose to start a basal insulin therapy on top of oral medication and then increase probably the insulin by rapid acting insulin to the meals, or you might even choose premixed insulin twice daily. And of course you get a higher number of injections and you get a higher complexity of this regimen, but on the other hand you could achieve better glucose control. So insulin therapy is might be quite complex. So what about the future? The future is, and this is a chart which shows what's now in development, and you see different targets, different phases, and you see what's being developed for diabetes treatment. And I will talk about two new developments which have been approved by EMA, at least quite recently. And this is one principle, this is principle of glucose absorption. Glucose absorption is sodium glucose cotransporter, which is SGLT1, which is in the intestine, being responsible for glucose absorption, and you have SGL2 in the kidney, being responsible for glucose reabsorption. And this is shown here. In this part, you see 90% of reabsorption by SGLT2. And there are families who have a glucosuria, no diabetes. And this is a norm variant actually. And what happens is they do have a mutation in the SGLT2, leading to less reabsorption of glucose. And this is a principle: when you block SGLT2, you increase urinary glucose excretion. And this is shown here, and you can have it in monotherapy or can combine it with different other drugs. You can consistently see a decrease of HbA1c between 0.8 and 1%. So this is a new drug increasing glucose excretion in the urine and improving HbA1c consistently by 1%. And in addition, it leads to weight reduction, because when you lose glucose via the urine, you lose calories, and you get a weight reduction of around 2 to 3 kilograms. The problem is, the problem is that if you have an increased concentration of glucose in the urine, you probably have more urinary tract infections or genital infections, especially in females. And this will probably be some issue with these type of drugs. You have an elevated urine volume, and you have an increase by just losing glucose and fluid, an increase in hematocrit, which also might be a problem. So when you look at the safety of those drugs, and one of the first is dapagliflozin, you might have an increased risk of urinary and genital infections. There have been some reports on increase of cancer, but you can see the numbers are very low, and I think there is no real signal, no biological signal for the increase of cancer. And there was no excess tumor rate in animals. But what's not shown on these slides, these drugs also lead to an increase in LDL cholesterol by 10%, and this is something we have to be careful. So we don't know about the long-term function, and this drug has recently got a positive opinion by EMA. It was rejected now by the FDA, not enough data, and the data on the tumors. But I think we'll have the drugs over the next 1 or 2 years on the market, and we'll see what to do with them. The second issue I would like to focus on is new insulins. And what you can see here is that you get a lot of new insulin formulations trying to have oral insulin phase 1, very early phase. We have some in the phase 3, and we have a new insulin now which have been approved by the EMA a couple of days ago. And this is degludec. Degludec is an insulin which has a very long half-life time. And the reason is that there is a fatty acid component which leads to polymerization and to binding to albumin. And this is when you inject insulin, usually you get hexameres, which are being dissolved subcutaneously to dimers, monomers, and being absorbed. So what you can do is actually you can promote multi-hexamer chain assemblage. And what you can see here, and in addition you can bind it to albumin. So you have a very, very slow release. And this is the difference to glargine. You know glargine, Lantus, which is a once daily insulin preparation. And you can see the half-life. The half-life of glargine, there's a different concentrations, but the half-life of glargine is 12 hours. And the half-life of degludec is 25 hours. So what you could eventually do is you could give this insulin only every second or third day. But this is not the plan. They will provide it every day to get a nice steady state. And this is quite important because what we don't like is within subject variability. So if you take the same dose of insulin, the same subject, you probably have different insulin levels every other day. And this, of course, compromises diabetes control. So what we want to have is a very low variability. And I think this is one of the advantages of this drug, that you get a very predictive variability or very little variability with this insulin. So this is a trial which is quite interesting because it's comparing degludec in two forms with glargine. What they did is actually they had a flexible injection of degludec versus a fixed injection of glargine or degludec with the evening meal. These are patients with type 1 diabetes. So this was an open label trial, and what you can see, the primary endpoint with HbA1c, the secondary endpoints have been, of course, different values like fasting plasma glucose, insulin dose, and hypoglycemia as well. So this was the schedule, and this was a very flexible schedule. So patient injected insulin one day in the morning, and the next day not in the morning, but in the evening. So there was a 40 hours difference between the injection time. And the other groups have been a fixed injection in the evening, glargine or degludec. So these are the patient's characteristics. Patients with type 1 diabetes, slightly overweight, long diabetes duration, and a moderate glucose control by 7.7% on average. What you can see here is the values of HbA1c as a primary outcome parameter, and you see there's no difference. So none of those treatments was better. So you can achieve the same diabetes control by flexible dosing. And what you can see is the weight change. What we can see, of course, if you introduce insulin, you see always a slight increase in weight, but there was no difference between both. This is the overall hypoglycemia. You see there's no difference as well, but the difference is in nocturnal confirmed hypoglycemia. And we know that our patients and we as well are afraid of nocturnal hypoglycemia. But you can see a 37% lower rate of nocturnal hypoglycemia, which I think is a good and important feature. So in conclusion, degludec allows a very flexible dosing with patients, and it reduces nighttime nocturnal hypoglycemia and has the same efficacy on diabetes control and weight. So what we need to do in the future is now, what we are doing now is actually we're having diet and exercise first. When we diagnose the patient, we're adding one drug, we're up-titrating the drug, we're combining the drug. We are most of the time above the target of HbA1c. So what we need to do in the future is we need to be much more aggressive in treating patients by combining new medications. And we have some new medications such as incretin mimetics, such as DPP-4 inhibitors, SGLT2 blockers, and new insulins, which carry a very lower risk of hypoglycemia. So at the end, I would like to turn to an important issue, which is important in this area as well. And this is the issue of bariatric surgery. We know that patients with morbid obesity, which is a BMI above 40, or those with a BMI above 35 and having comorbidities such as diabetes, are eligible for bariatric surgery. And we have some methods for bariatric surgery which might be mainly restrictive, which might be mainly malabsorptive, and which might be a combination of both. And what has been shown with these type of surgery, this is a SOS study in New England Journal of Medicine. What you can see is that with bariatric surgery you can achieve a very good weight loss, up to 60–70% of excess weight. And what happened in the surgical group, and this was the first study to show that bariatric surgery decreases mortality, is what you could see is that overall mortality over 15–20 years was decreased by 30%. And what else was decreased was coronary artery disease and cancer. And this is another study looking at different published studies on patients undergone gastric bypass surgery, and they looked at long-term mortality, and what you can see is that you had a very nice consistent decrease of long-term mortality. But in addition, you had a dramatic decrease of type 2 diabetes. You had type 2 diabetes remission in a very high percentage, and quite impressively you had an almost 62% decrease in the incidence of cancer. So you can see that the cause-specific mortality was decreased for coronary artery disease, for diabetes, and for cancer. And I think this is quite impressive. So when you look at patients with diabetes who are morbidly obese, and you have different ways of reducing weight, you can have different rates of the amount of excess weight loss, and of course you can have different rates of diabetes, let's say not resolution, but it's some sort of, probably for some time you get rid of the diabetes. And we have very new data of our own group that you can achieve, let's say, 75% diabetes remission after 5 years with gastric bypass, which is quite impressive because those very obese patients are very hard to treat. You have to use high doses of insulin, you increase the weight even more, and you never get good control. But it's a very important point is when you have those type of surgery, which has some malabsorptive component, what you need to make sure is that you get adequate resorption. And one of the big problems is the protein resorption. So you have to be very careful in the patients that they have an adequate amount of protein. And of course, you have important other micronutrients which might be deficient in patients. And we must not forget that, for example, vitamin D is deficient in most of our patients even before surgery. So if you look at vitamin D levels in patients with morbid obesity, they don't expose themselves to sun enough, then you see always a difference. So what you need to do is you usually need to substitute these, and this means a lifelong substitution. And so if you do bariatric surgery, you have to be sure that you have an adequate follow-up and you have a good collaboration with endocrinologists, dietitians, nutritionists. And this is what the patient needs. The patient after gastric bypass surgery or any other bariatric surgery needs a daily supply of multivitamins, vitamin D and calcium. They need intramuscular vitamin B12 substitution, and many of them need iron substitution as well. And this is a suggested postoperative follow-up. And I think the main message must be, if you do bariatric surgery, you have to make sure that the patients are followed up adequately. So I hope I could give you some overview about diabetes treatment, how to control type 2 diabetes, show you some new promising drugs, and some bariatric surgery methods to lead to diabetes remission. And we must not forget, if you have a patient with type 2 diabetes, it's not important only to control for glucose, meaning achieving adequate HbA1c goal, but it's extremely important to look for blood pressure, and extremely important to look for LDL cholesterol levels. And usually we can target those high cholesterol levels with statins. We must not forget that the LDL in those patients should be below 70 milligrams per deciliter, and we should try to achieve a blood pressure of less than 135 over 85 millimeters. Thank you.